Welcome to Bullet Point Nursing. My name is Dr. Goldstein. Now, whether you're a nursing student, getting ready for the NCLEX, or getting ready for nurse practitioner school, this series is here to help you. Over the course of this series, we're going to go through essentially the entire nursing pharmacology curriculum. All of these notes can be obtained from our website, and it is highly recommended that you print those out, follow along, and take notes as we progress on all the different comments that we deliver in this lecture. In this video, we're going to be going through our mental health content. So let's go ahead and start. First, a few notes about, in general, treating patients pharmacologically for mental health disorders. Most of these medications, if not all of them, need to be tapered down when they are stopped. We would never abruptly want to take a patient off of their depression or anxiety medication, because even if they're doing well now, they could be doing well strictly because they're on their medication. If we stop their medication, suddenly they may not be doing very well. We want to always slowly take them off of it. We also need to critically educate our patients on having realistic expectations for the medications that we're giving them. We should never give a patient their new prescription for sertraline, Zoloft, or something like that, and tell them, take this pill and tomorrow your life is going to be sunshine and rainbows. That's just not reality. And if we do that, we're setting them up for failure instead of success. We need to educate them that this is not going to fix your problems. This is just going to help you get through your problems. It's going to help you be the better version of you. Whatever that medication does, we want to realistically educate them on what that medication can do for them. We also want to educate them on the time frame. Most of these medications take several weeks till they begin to work, and could be even longer until you get the full effects. You want to make sure the patient understands that, so again, they have realistic expectations. Any patient who is being treated pharmacologically for a mental health issue, such as schizophrenia, depression, anxiety, etc., must also be getting therapy. It doesn't mean that if they say they're not going to therapy, that I'm just going to stop prescribing their medication, but they should constantly be educated at each visit that they need to get into therapy in order for the medication to work to the best of its ability, in order for the patient to get the best healing possible. A CAM that we have for this chapter, CAM again is complementary alternative medication, is St. John's wort. This can be very critical. Any patient who is on a medication for mental health has to be queried if they're taking any over-the-counter or complementary supplements, because St. John's wort, as we're going to learn in a little bit, can increase a patient's serotonin level, thereby leading to serotonin syndrome. So what is serotonin syndrome? Serotonin syndrome is a constellation of symptoms. It includes hypertension, it includes fever, altered mental status, and it happens when a patient's serotonin level gets too high. What causes a patient's serotonin level to get too high? Well, there are a few things that cause it. The two most common causes of serotonin syndrome is a patient taking multiple serotonin medications. So this could be any of the things we're about to learn about, let's say sertraline with amitriptyline, or if you are watching these videos in order, we just learned about serotonin 5-HT receptor agonists, which are the triptans. Those also are serotonin medications. St. John's wort is also a serotonin substance. If a patient's taking multiple of these, especially if they have their primary care prescribing them something for anxiety, and they have their psych MD prescribing them something, and they're not talking to each other, a patient can end up on too much of a serotonin medication. So let's go ahead and let's start talking about the different drug classes. And we're going to start with the first one of SSRIs. Selective serotonin reuptake inhibitors. This is one of the most prescribed drug classes in the United States. And this is a pretty big drug class. And because they're so popular, I did list quite a few of them here. On the list, we have sertraline, fluoxetine, escitalopram, citalopram, and paroxetine. You likely recognize at least some of these brand names: Zoloft, Prozac, Lexapro, and so on. How do these medications work? Well, the good news is if you know the name of the drug class, you also know the mechanism of action, because it's one and the same. It selectively inhibits the reuptake of serotonin. Let's make sure we understand that. We want to have an elevated level of serotonin to treat a patient that has depression or anxiety. So how do we get that elevated level of serotonin? Well, I can't just draw up some serotonin in a vial and give it to you. So what can I do? Well, the body is constantly producing serotonin, and it's constantly getting rid of serotonin. If I can stop that, if I can make the body keep producing serotonin, but suddenly it stops getting rid of serotonin, that would increase my serotonin level. And that's exactly what these drugs do. Selective serotonin reuptake inhibitors, almost universally referred to as SSRIs, work by decreasing the body's ability to get rid of serotonin. If the body can't get rid of serotonin, yet it keeps making serotonin, our serotonin levels go up. This drug class is used for depression and anxiety, and it is the first line agent for both of those diseases. Again, it's the first line agent. It does have an off-label use, which is actually a side effect / adverse effect. The adverse effect here is that it delays orgasm. In a female, this is generally a bad thing, as it makes them have a harder time achieving an orgasm, or even that they cannot orgasm. As opposed to in a male, this is actually used to treat premature ejaculation because of the same problem. It delays orgasm, which in a male treats premature ejaculation. That's an off-label use for this drug class. When used for that, we use specifically paroxetine. Other adverse effects of this drug, besides the sexual dysfunction that we just mentioned, is insomnia. Now, NextGen testing tip: which of the following medications needs to be taken in the morning? This is always something that needs to be taken in the morning. Anything that says insomnia, because we don't want something that makes you stay awake. We don't want to give it to you at nighttime. This medication is taken daily, and it takes roughly 2 to 4 weeks for the medication's effects to kick in. You need to educate your patient on that they will not begin to experience the effects until roughly 2 to 4 weeks. Again, set them up for success. Don't tell them you're going to feel better tomorrow when that's not reality. Of all the depression and anxiety medications, this one is generally considered a pretty safe one for a patient to take in pregnancy. That's our first line drugs, the SSRI, for both depression and anxiety. Let's move on to another class, and these are not going to be in any particular order. They're just not first line. Any drug that is not a first line agent is usually referred to as an alternative drug. So we have our first line drug and we have alternatives. Why would we go to alternatives? There could be a number of reasons. It could be because the first line didn't work. The patient's allergic to the first line. The patient can't get the first line because, let's say, they're pregnant, or any realm of these conditions. But let's move on to several alternative options for depression and anxiety. The next one we're going to look at are SNRIs, also known as serotonin norepinephrine reuptake inhibitors. And again, we have a winner here because the drug class and the mechanism of action is the same, which it should be through most of pharm. They tried to make things a little bit easy for nurses and nursing students once in a while. And this is a good example because if you remember the drug class, usually that helps you with the mechanism of action, especially if you're going for the NP level. The mechanism of action is critically important to know for almost every single drug. What drugs are we talking about here? The two that I have listed are duloxetine, which is Cymbalta, and venlafaxine, which is Effexor. How do these work? Exactly like the drug class sounds. It blocks the reuptake of serotonin and norepinephrine, thereby increasing the levels of serotonin and norepinephrine. These drugs have several indications. We already said depression, anxiety, not first line, but they are commonly used for that. And these are also used for migraine prevention as well as fibromyalgia. Side effects that these drugs have, there's quite a few of them. They are used, they can cause sexual dysfunction, which we already discussed, insomnia, which we already discussed. But now we start to mess with not only serotonin like the last ones, now we start to mess with norepinephrine. So because of the norepinephrine side, norepinephrine, if you remember, is the primary neurotransmitter of our fight or flight response. So we start to mess with that. And because of that, this can cause hypertension. Again, these are not common. It's just what we have to educate patients on. It can cause hypertension. It can cause orthostatic hypotension and a few other things. Keep in mind, anytime you see orthostatic hypotension, that should automatically in your mind mean I need to educate my patient to slowly get up from seated positions, to not jump out of bed in the morning. When I change their dose, they need to take it easy the first 1 or 2 days because we don't know how it's going to affect them. Anytime you see orthostatic hypotension, there's a risk to the patient passing out, and you need to educate them about that to slowly get up from seated positions and so on. These drugs have a black box warning, just like the SSRIs, that they have an increased risk for suicide and suicidal thoughts. Keep in mind that's a very low risk. That's certainly not a reason to take it, not to take it. Obviously, if these drugs were causing everyone to commit suicide, we would never use it. We certainly wouldn't use it for a depressed patient. The next drug class that we're going to talk about are tricyclic antidepressants. These are a much older class of drugs than the first two that we discussed. And that's not a bad thing, but we have the newer ones that are better, like the SSRIs, but these are sometimes still used. The drugs in this class include amitriptyline, nortriptyline, doxepine, and a few others. These drugs actually work the exact same as SNRIs. It blocks the reuptake of serotonin and norepinephrine, increasing the level of those two transmitters. It just does it in a slightly different manner, which is why it's in a different drug class. What is this used for? It's used for depression. That's what it's indicated for. Plus, it has off-label uses for fibromyalgia, irritable bowel syndrome, migraines, anxiety, and more. Do keep in mind, I can't imagine ever an NCLEX or any undergraduate nursing question asking you which is an off-label indication and which is a regular indication. Those are all lumped together. However, at the nurse practitioner level, we do usually want to know what's a proper indication and what's an off-label indication. The side effects of these drugs are anticholinergic effects. Anticholinergic effects, you may not have learned yet what that is, and I'm not going to cover it in this video. That's coming up in a later video. However, once you do learn all of that, there's a lot to know, and you will have to be alert for any question related to that on any of your tests. ECG changes. Remember here, again, NextGen level testing, anytime you see something on ECG changes, you should be alert. That means I need to have my patient on a monitor. I need to be watching their electrolytes because ECG changes and electrolytes go hand in hand. So a lot of these different things, get ready for it because that's what they're going to be testing you on. CNS depression, again, so what would be a patient education point? Well, you may experience drowsiness, you may experience weakness, you may experience sedation. If you see CNS depression, you have to be ready to make that connection. I didn't mention alcohol, but you see CNS depression, you should already know this should not be taken with alcohol because of a risk of further depressing your CNS. These medications also can cause weight gain. Again, that's not super common, but it is a known issue that you should educate your patient about. Black box warning, same thing, risk for suicide. And again, this is another alternative option. It's not a first-line option. The only first line for depression and anxiety were the SSRIs. The next drug class we have are the MAOIs, one of the oldest drugs that we have for depression. The drug over here is going to be phenelzine. That's usually the prototype drug. And so what is this drug? Well, the mechanism of action is exactly what it sounds. It inhibits monoamine oxidase. But what the heck is monoamine oxidase, or MAO? MAO is responsible for getting rid of norepinephrine, dopamine, epi, and serotonin. So it's responsible for getting rid of all of these neurotransmitters. If I block the body from getting rid of them, then what do? Same thing we've been talking about all the time now. That will increase the level of all of these neurotransmitters. So it's going to increase my norepi level, my dopamine level, my epinephrine level, and my serotonin level. What do we use this for? It's labeled for depression. It's also used off-label for anxiety. It has the same black box warning as pretty much all of the antidepressants. However, MAOIs interfere with a lot of different medications. Now, I want to be really clear about something. There's two ways of interfering. One is, well, this drug can cause, let's say, abnormal GI absorption, so don't take them together. Take the pills, let's say, 2 hours apart. This is not that type of interaction. This type of interaction means for as long as you are on an MAOI, you cannot be taking X, Y, and Z. So there's two different types of ways that drugs interact. One is physically, they shouldn't be taken at the same time or within an hour of each other. And one is they shouldn't be in your system together, period. In this case, they shouldn't be in your system together, period. This is one of the highest number of drug interactions is with MAOIs. And for this and many other reasons, we don't really use this. This is usually not only an alternative agent, but it's usually a last resort if all other options are off the table or have failed. Let's keep going. This drug has many contraindications, and I'm not going to list all of them. There was too many. The side effects, again, we have orthostatic hypotension. But here we have another one. This drug interacts with any food that contains tyramine. Now, a lot of things contain tyramine. Any food that contains tyramine is going to interact with MAOI, monoamine oxidase inhibitors, and it's going to cause the patient to have hypertension to the point of even a hypertensive crisis. You need to educate your patient, Give them a whole list. You can Google it, print it out, all the foods that contain tyramine the patient needs to avoid. It's a pretty extensive list, and that's a pretty big deal breaker for a lot of patients when this medication comes up. But for those that it helps, I guess it's considered worth it. But each patient needs to make their own decision with their provider. So again, you would definitely need to educate your patient to avoid tyramine and what would be the effects of it. It would cause hypertension, even uncontrolled hypertension. And again, we have the same insomnia and the same anticholinergic effects that we've seen previously. Again, insomnia, make sure you have them taken in the morning. Anticholinergic effects, we're going to learn a ton about that when we get to the video on cholinergic medications. Let's keep going. Patient education. Again, they have to avoid foods that contain tyramine. And because this drug interacts with so many other drugs and it stays in our system roughly 14 days, any drug that it interacts with cannot be taken not only during the course of treatment with an MAOI, but not even for 14 days following the end of treatment with an MAOI. This is really fair game for a test question. Patients prescribed this medication. When should they start taking it? Day 1, day 10 after the MAOI, day 14, etc. This is definitely something that you should be aware of. Next, we have another medication. It's called Wellbutrin, is the brand name, or Bupropion. The mechanism of action is not completely understood. However, we know that it inhibits the uptake of norepinephrine and dopamine. Again, we've been talking about that this whole time. Inhibiting the uptake increases your level of norepinephrine and dopamine. What do we use this for? We use it for depression. We use it off-label for ADHD because it helps focus. And we also use it off-label for bipolar disorder. However, it also has another labeled indication under a different brand name, and that is Zyban. And Zyban is also the active ingredient in bupropion, but that is used to help patients quit smoking. This medication has a risk for seizures. That risk is most prominent if the drug is started too high or the dose goes up too fast. If we don't do those two things, it has a very low risk of seizures, but the risk of seizures is there almost exclusively when we go up on the dose too fast or we go up on the dose too high. This medication also causes insomnia, so again, make sure to take that in the morning, educate your patient on that. And again, when you see that drug cause insomnia, you need to be ready for non-pharm interventions to help insomnia, okay? And we're gonna get to those in just a few minutes. Black box warning, again, same thing, risk for suicide, as well as other neuropsychiatric events. The next drug that we have is Trazodone, and you'll notice this one and the last one, I didn't put a drug class there because depending what textbook you look at, it doesn't fit neatly into any one drug class. So I sort of left it out, and I wanted this to be able to be used universally with any textbook or any school curriculum that you're using. So what's the mechanism of action? Well, it inhibits the reuptake of serotonin, and we've been seeing that a whole bunch already. And what else does it do? It also blocks histamine and alpha-1 receptors. Now, we haven't covered histamine or alpha-1 receptors. Histamine you probably recognize because that's what Benadryl does. It blocks histamine. It's an antihistamine. So, and the alpha-1 adrenergic receptors we'll get to when we get to that lecture. So what is this used for? It's used for depression. It's also used off-label for aggression and agitation due to dementia, and it's used to treat insomnia. Very interestingly, this drug is actually used off-label for insomnia more than it's used on-label for depression. Because for depression, we have so many other drugs that are better, versus insomnia, we don't have any one best drug. Not everything has a first-line agent. You know, if you have a headache, there's basically 2 first-line agents, Tylenol or Advil, versus over here, we don't have a clear first-line agent for insomnia, but this is one of them, and this does work pretty well with limited side effects in most patients. So this is actually used more for insomnia than for depression. What are the side effects here? Dizziness, drowsiness, dry mouth, ECG changes, and orthostatic hypotension. Again, keep in mind, there's always going to be more side effects. I don't list everything because every drug can cause anything from a headache to death. I listed the ones that are most common to see on a test and the ones that you are most important to educate your patient about. This drug does have the same black box warning as every single antidepressant, I think, that it has a risk for suicide. That's the end of the depression. Let's talk about anxiety. So most of the drugs we just covered were both depression and anxiety, not all, but most. This next one is another one for anxiety and depression. However, this one's flipped because its first line, its actual labeled indication is anxiety versus off-label use is depression. It's not used that common, but it is absolutely out there. It's buspirone or Buspar, and this has the same disadvantaged side effect that we saw earlier of sexual dysfunction, the inability to orgasm, and it can also cause EPS or extrapyramidal symptoms. And we're going to talk about that in just a minute. Let's talk about another drug for anxiety, and that are the benzodiazepines. Of all the drugs for anxiety, this is the only one that we're going to deal with that is a narcotic that has a high risk of abuse and dependency. But these are also the most powerful drugs to use for anxiety because these are actual sedatives. So what drugs are we talking about? Lorazepam, diazepam, alprazolam. You recognize some of these names as Ativan or Valium, Xanax. And these are benzos, and we're going to talk about benzos again in a little while when we get to the lecture on neurology, because these are also used for seizures. Over here, they're used for severe anxiety. They're usually taken PRN as needed for when a patient feels or is likely to experience their anxiety. How does it work? It's a GABA agonist. So GABA is GABA aminobutyric acid, and it's an inhibitory neurotransmitter. The way I like to teach it is that it's the brakes of the brain. Now, if I give you a GABA agonist, that means I'm giving you more, essentially, more effects of GABA. So if I'm giving you more of the brakes, that means I'm slowing things down more. And that's how it works. And it works for a number of different things. The next line, what do we use it for? We use it for seizures. We use it for insomnia. We use it for anxiety, sedation, muscle relaxant, and the list goes on. It's used for alcohol withdrawal and more. And let's go through it. Let's see if it makes sense for each of them. Seizure disorder. Well, in a seizure, the neurons are flying way too fast. If I hit the brakes, I slow things down. I fix the seizure. Insomnia. Your mind's going too fast, so your body, this slows things down. Again, gives you that sedation. That helps you with your insomnia. Anxiety, that's an easy one. Obviously, if you're getting all anxious, if I give you a sedative, it takes the edge off, and so on and so forth. So adverse effects, because this is a sedative, it can cause muscle weakness, it can cause hypotension, sedation, respiratory depression. Every one of those is a potential question. Remember, on NextGen testing, it's going to have second level questions. So it's not going to be, what is a side effect of this, muscle weakness? No, it's going to be something like, what patients would you be most concerned about when they complain of inability to get out of bed? And it would be if they're overdosing on their benzos, things like that. Respiratory depression, of course, make sure that you're monitoring their vital signs. What would be a priority assessment? Well, if any respiratory assessment is an option, then that's the answer. Also, if any blood pressure assessment is the option, whether that's cap refill, whether that's their blood pressure, whether it's their mental status, because we can use mental status as one of the ways to assess blood pressure. We know that when a patient's blood pressure gets too low, they become altered. Same thing, look out for all of these things on the tests. These drugs have a black box warning not to mix with any other CNS depressants. We already know that. It can cause respiratory depression, and it can cause abuse and dependency. These are a controlled substance, Schedule 4, like we said in our very first video. These drugs are considered first line for seizures. We're not talking about seizures today, but just an FYI, because that is where we're going to get even more into this specific category of drugs. Patient education, do not take it with alcohol. Risk for abuse and dependency, but again, educate your patient. If this is properly prescribed, it's not likely to cause an issue. Now, we have a reversal agent for this, just like we had for opioids. The reversal agent here is called flumazenil, which is, the brand name is Romazicon. And this drug is used to reverse a benzo overdose. So if I gave a patient a benzo, let's say for sedation because they were getting really anxious, and now they're completely out of it. Their GCS is way down, their mental status is way down. I need to get them out of it. I could give them flumazenil. It's not used a whole lot, flumazenil, and we're not going to get into that drug, but that is an option, and it's certainly fair game for a test of what drug would be most likely to be given for a patient who is having a benzo overdose, or a patient who's prescribed alprazolam and is now unable to be awakened, or any way that they can ask that question. Make sure you're ready for it. Another drug that's used for anxiety that we're not going to discuss here is propranolol. Propranolol, you probably recognize, LOL, is a beta blocker or a beta-1 adrenergic antagonist. This drug is used for specific types of anxiety, mostly related to situational anxiety, such as test anxiety. I know you guys are nurses and nursing students, so you have no idea what anxiety is, but for patients that do, we sometimes give them this to help with situational anxiety, such as for tests. This works best because this has nothing to do with the mind. This doesn't deal with serotonin and norepinephrine and all the things we've been talking about. This simply slows down the cardiovascular system. And by slowing down the cardiovascular system, by them not feeling their heart racing, by not feeling the palpitations, by not feeling their blood pressure going up, that calms them down. So what does it do? It treats the physical manifestations of anxiety, specifically situational anxiety, and those physical manifestations would be tachycardia, palpitations, or hypertension. Next, let's move on to bipolar disorder. The drug class that we're going to talk about first is a mood stabilizer, and that has one drug in it. It's called lithium. The mechanism of action of how this works is not exactly known, but we do know that it has to do with sodium levels in the body because this can mess with your sodium levels. What is this used for? It's used for depression. It's actually also used off-label, or I'm sorry, it's used for bipolar disorder, and it's also used off-label for depression. Because this drug has a very narrow therapeutic index. Remember from lecture 1, a narrow therapeutic index means it starts to work over here, but it becomes toxic over here. Well, in this case, that's about this big. So we need to really thread the needle on the right dose because too little, it's not going to work, and even a drop too much, and they're going to become toxic. What are the adverse effects of this drug? It can have cardiac effects, renal effects, neuro effects. It can cause nephrogenic diabetes insipidus, which we're going to get to in a whole different lecture. It can cause polyuria, meaning that the patient's peeing a lot. It can cause a lot of adverse effects. However, again, like most of the time, we don't normally see these, but you do need to know them, certainly for test purposes, and as well as to educate your patients. Polyuria, we haven't seen that one, so let's talk about that for a second. That means peeing a lot. So what does that mean? NextGen questions. If a drug causes polyuria, what might you see on the test? What drug would you encourage fluids in a patient? Well, if it causes you to pee a lot, that means you can get fluid depleted, dehydrated. I would encourage you to drink a lot. So lithium, encourage your patient to drink a lot. Think of other things like that. What can you come up with of some other way that the test might try to connect polyuria with the test question? Things like patient expect to be thirsty a lot. Because you're peeing a lot, you're low on fluid, the body kicks in the thirst mechanism. Again, think of all the ways that the test can make this connection and feed them to it so that you're ready for it. This drug has a black box warning that you must monitor their lithium levels because of how narrow the exact drug dosage needs to be. You need to keep a real close eye on it to make sure that you're getting the right dose and you're not getting toxic on this medication. And we already talked about that the lab needs to be monitored regularly because of the narrow therapeutic index. And we already talked about that this patient is going to be peeing a lot, so we need to educate them to expect to be thirsty, to expect to be taking a lot of fluids, etc. The next drug we have, still on bipolar, the drug class is valproates, and the drug name is valproic acid. The mechanism of action of how this works is it prolongs sodium channel inactivation, plus it's a GABA agonist. So you need to be able to be ready. So what kind of effects is this drug going to have? Well, because it's a GABA agonist, you might feel a little bit of drowsiness or a little bit of sedation. What is this drug used for? It's used for seizures, migraines, and for bipolar disorder. It does have 3 black box warnings: hepatotoxicity, so monitor the AST, ALTs, be alert for jaundice, tell the patient to report any change in skin color, yellow skin, anything like that. Again, get ready for any type of question they can throw at you. Know this stuff as well as possible. Highly teratogenic, so if it's a patient that's a female childbearing age, this would not be an ideal medication, and that's fair game for the test. And finally, pancreatitis. We haven't gotten to pancreatitis yet, but there's a lot of signs and symptoms that we're going to discuss at a later point that you should be ready for in this drug to look out for. Because remember, every time we give a drug, we assess what we're treating beforehand. We assess the effects afterwards. So not only what we're treating, but afterwards we assess for any side effects, especially the primary ones, of the drug that we're giving. The next option that we have for bipolar disorder is lamotrigine, which is Lamictal. The mechanism of action for this one is that it prolongs the sodium channel. And what that does is that blocks specific electrolyte balances in the brain. So in this case, what does this drug do? This treats seizure disorder and this treats bipolar. And we are going to see it again when we get to seizures, when we get to our neuro lecture. It has a black box warning that it can cause SJS and 10. SJS is Stevens-Johnson syndrome, and 10 is toxic epidermal necrolysis. These are potentially fatal skin diseases, and we have to be very careful with that. Anytime you see that, and you're going to see that a few times in pharm, you always want to know to assess your patient's skin, educate them to immediately alert the provider for any changes in their skin, any dermatological issues, things like that. So what did we talk about for bipolar disorder? Well, we talked about valproates, we talked about lithium, we talked about lamotrigine, which is a seizure drug. Again, I didn't put the drug class here. Technically, it would be an anticonvulsant or an anti-epileptic. And we have a fourth option that we're going to discuss at the end of this lecture, which is antipsychotics that we haven't gotten to yet. Since you are still here watching and hopefully enjoying this lecture, please go ahead and hit the subscribe button. All of the content on this channel and on our website is 100% free. It's there for nurses, nursing students, nurse practitioner students. This channel is supported simply by you hitting the subscribe button and enjoying the channel. The next drugs we're going to talk about are for ADHD, attention deficit disorder, ADD or ADHD. And what drugs are we talking about? We're going to start with three of them: methylphenidate, amphetamine, and dextroamphetamine. These drugs are all in the drug class CNS stimulants. These drugs work by causing the release of norepinephrine and dopamine. Both of those are neurotransmitters related to the sympathetic nervous system. Both of these stimulate your CNS system. What do we use it for? We use it for ADHD, and we actually also use it for narcolepsy. It does have a black box warning that it's linked to abuse and dependency, just like all controlled substances have. This is a Schedule II. That's the highest level controlled substance in terms of legal drugs because it's the highest risk for abuse and dependency. It does have two side effects. One is that it can cause weight loss, and the second is that it can help you stay awake, aka insomnia. Help you stay awake sounds like a good thing. Can't fall asleep is a bad thing, but they're both the same thing, just a matter of perspective whether you like it or not. However, it is abused for both of those items. So be alert for that it is not to be used for weight loss. It is not to be used to stay awake endlessly. Even if you're a college student, even if you have exams coming up, that's not a reason to be taking this just to stay awake endlessly, but it is abused for exactly that. And these drugs are the first line treatment options for ADHD because they are the most effective. Another option that we have for ADHD is atomoxetine, which is Strattera. This is a non-CNS stimulant, CNS stimulant. So what does this do? This is less effective than CNS stimulants, but it does have a lot of the same properties. It blocks the reuptake of norepinephrine, which we've seen a few times already today, thereby increasing its effects. We use this for ADHD, but it's not as effective. So when do we use it? Mostly we use this when someone has a history of drug abuse and we don't want to try putting them back on a drug that has a risk for abuse, or they just don't want to try it in the first place. They're a little iffy on going on something that has a risk for abuse and dependency. And those drugs do have a relatively high risk. Obviously, they're Schedule II, that's the highest level. Because it's not a controlled substance, that's its big advantage. It's not as effective, but for the patients that it works in, that's great that we have a drug that works for them without them being on something that has the high risk for abuse and dependency. The next drug we have is modafinil. Modafinil is used for narcolepsy, sleepwalking. It's also used for ADHD and a few other things. The off-label use for this is also depression and fatigue from various sources. The mechanism of action of this drug is not fully understood. However, it does work by increasing dopamine in the brain. I'm sorry, narcolepsy, falling asleep during the day. Controlled substance, this is a Schedule IV. That's a relatively low-level controlled substance, but it is there. Anytime you are treating a patient for insomnia, which is what we're going to get into now, we always got to talk about non-pharm interventions, so let's start there. The non-pharmacological interventions for insomnia, we have a few of them. Most of them, it's reducing your activity before bedtime, reducing the lights in the room, reducing your food before bedtime. We don't want the GI system all giddy because it just got a whole big meal and then trying to pass out. We want to reduce the temperature in the room. We want to reduce caffeine. We want to reduce nicotine. Nicotine is a stimulant. And we want to reduce alcohol. And don't even start. I know alcohol makes you pass out, but that's not what we're going for. So non-pharmacological interventions for insomnia, what are we going to do? Lower the lights, lower the noise, lower the activity, lower the temperature, lower the caffeine, lower the nicotine, lower the alcohol. Those are non-pharm interventions. Remember all those drugs that we've been talking about that have a risk of insomnia? Any one of what I just said are all fair game intervention or patient education points for someone that has that's taking a medication that can cause insomnia, in addition to someone who actually has a diagnosis of insomnia. So the drug class we're going to talk about right now is going to start with Adora. Now, I want to be clear when we get to this. So far, ADHD, we had a clear first-line agent. That was the CNS stimulant. Depression, anxiety, clear first-line agent, SSRIs. We do not have one for insomnia. There's going to be different ones that work for different people. A lot of patients, especially in my practice, it takes multiple tries until we get the right medication that works for them. But keep in mind that we do have a lot of options to help them, and generally we're able to find the right one. The first one we're going to talk about is a DORA, dual orexin receptor antagonist. Not only do you have the drug class, what else do you have? Good, you got the mechanism of action. So by blocking the dual orexin, orexin A and orexin B, that suppresses the wakefulness drive, ergo putting you to sleep. What is this used for? It's just used for insomnia. This is a relatively new class of drug. If I'm not mistaken, it's been around less than 5 or 10 years. These are a controlled substance, as are going to be a whole bunch of our insomnia medications. Another drug that we have for insomnia, this one's actually over the counter, is the antihistamines, the histamine 1 receptor antagonist, to go by its proper name. And we're going to learn more about this when we get to pulmonology and we get into allergies, but here's 2 of them listed, doxylamine and hydroxyzine. One of those is over the counter, doxylamine. One of them is by prescription, that's hydroxyzine. How do these work? You already know they're antihistamines, which means they block histamine, which results in sedation. What do we use this drug class for? Well, right now we're talking about insomnia, but we're going to talk about this again when we get to nausea in pregnancy. We're going to talk about this again when we get to allergies. And also, we're going to double up now because this lecture, we're also talking about anxiety. And these drugs, specifically hydroxyzine, is also used for anxiety. Doxylamine is available over the counter. We already said that. So again, that's another option that you have for the treatment of insomnia. That's a lot where a lot of people start, is they start with the over-the-counter antihistamines. Next, we have the BZRAs, or benzodiazepine receptor agonists. And this is very famous. The drug here is zolpidem or Lunesta. Sorry, I'm going to butcher the name of the other one, so I'm not going to try it. But zolpidem or Lunesta, Ambien or Lunesta. Ambien, very, very commonly used, especially when it first came out. These drugs work the same as benzos. So we already talked about what benzos are with anxiety. They are GABA agonists. They hit the brakes on the brain, causing CNS sedation. These work the same way. They're just not technically called a benzo. The indication for them is just insomnia. That's what we use it for. These drugs should not be used long-term. That goes for the same with the DORAs. They're not ideal to be used long-term. Same thing here. Generally, if a patient is going to be on this long-term, they're not going to be able to come off of it, certainly not easily. They're going to have a lot of insomnia whenever they do try coming off of it. The next drug class we have is melatonin receptor agonist. Most of you are probably familiar with a CAM for insomnia is melatonin. Tons of people take that. It's over the counter. Melatonin receptor agonist is the same thing, except it's about 8 to 10 times stronger than the over-the-counter melatonin. So it's significantly stronger. It does the same thing, but it does do it at a prescription strength level. What is it used for? It's just used for insomnia. This is not a controlled substance, so this has less risk for abuse and dependency. And of all the ones to be on long-term, this is definitely one of the better options, certainly of the prescription version. Don't forget, we're not talking about it again, but trazodone that we talked about 10 minutes ago is also used for insomnia in addition to depression. And that one, remember, we said is actually used more for insomnia, but I put it under depression because that's what it's labeled for. The next drug class we're going to talk about, tricyclic antidepressants. We already talked about this. You're not losing your mind. We just went over this for depression, but it does have a drug here that's also used for insomnia, and that is doxepine. Doxepine specifically. The rest of them are not really used for insomnia. And we already discussed the rest of this drug earlier. However, the mechanism of action, we left out this part. It also serves as a histamine antagonist, aka antihistamine, and that's why it helps out for insomnia. Obviously, melatonin, we already discussed, is a known CAM for insomnia. Let's finish up by talking about the medications for schizophrenia. So those are the antipsychotics. The antipsychotics are split into 2 groups. Actually, they're split into multiple groups, but we're going to start with putting them into first generation and second generation. Even within the first generation antipsychotics, we have 2 varieties. We have the phenothiazines and the non-phenothiazines. So we start off with the first 2, chlorpromazine and fluphenazine. Those are both phenothiazines. What does that mean, or how do these work? The mechanism of action is they block dopamine 2 receptors. And you're going to see the next drug class as well. Same thing. All of the antipsychotics, how do they work? They block dopamine 2 receptors. What are these used for? They're used for schizophrenia. They're also used off-label for bipolar and nausea. Nausea we're going to get to when we cover GI, but there are some drugs that are phenothiazines. They're not actually any of these, but they are phenothiazines, and they are used to treat nausea. Haloperidol, out of the three on this list, is the only one that's used for an acute episode of psychosis. The rest of them are meant for long-term management to keep symptoms under control. But if someone comes in an acute psychosis, on this list, haloperidol would be the only correct option. The adverse effects of this drug is drowsiness, because it does have a sedative component to it. Anticholinergic effects, I know you don't know yet what those are if you're going on these in order on these videos, but we're going to get to that. Sexual dysfunction, again, we discussed that in depth. Orthostatic hypotension as well. Now, the antipsychotics, specifically the phenothiazines, have another whole issue, and that is that they cause EPS, or extrapyramidal symptoms. We saw this once before earlier today, but let's cover what that is. EPSs are acute dystonia, Parkinsonisms, akathisia, tardive dyskinesia, and more. These can be treated symptomatically. For example, Parkinsonism may be treated with benztropine, and just depends what EPS the patient's presenting with. Some of them are treated with benztropine, some of them are treated supportively. It depends what's going on. But those are EPSs, and these first generations, especially the phenothiazines, are have a high risk of causing the patient to develop these EPSs. Another famous, at least for testing purpose, effect of taking these drugs is neuroleptic malignant syndrome, or NMS. This is a rare but potentially fatal reaction that presents with rigidity, high fever, and more. Again, this is more likely in the first gen versus the second gen, and within the first gen, it's more likely from the phenothiazines than the non-phenothiazines. And if a patient does develop this, it can be treated with dantrolene, which we're going to talk about in a separate lecture. These drugs have a black box warning that while they are used for acute psychosis, specifically Haldol, and all of them are used for psychosis in general, none of these are to be used for dementia-related psychosis. That is a different pathophysiology, and it gets a different pharmaceutical treatment. Antipsychotics have a high incidence of medication noncompliance, and of patients with schizophrenia that do stop taking, against medical advice, stop taking their medication, they have an extremely high rate of relapsing. So we want to really educate your patient, not only on the medication, not only on the disease, which we always do. That's what we're really good at as nurses and nurse practitioners. But we want to also make sure that they are set up for success. Make sure the patient has reliable access to the medication, has reliable source of and support of someone that can make sure that they're follow up and that they're taking their medication. Because if they don't take their medication like they're supposed to, unfortunately, they have a very high risk of relapsing and getting all the symptoms back. And as most of you are familiar with or going to become familiar with, schizophrenia is something that does require to have it under control. Now we have the second generation antipsychotics, also known as atypical antipsychotics. And you may see other names for this, depending on what textbook your school or program is using. Some of them call it dopamine stabilizers or dopamine serotonin stabilizers, or second gen or third gen, or atypical is a pretty common one across most textbooks, and that's what I put over here in parentheses. So what are we talking about here? There's a whole list of these. Some of the brand names you're probably familiar with: Latuda, Zyprexa, Seroquel, etc. Again, these drugs block dopamine 2 receptors, just like the first generation antipsychotics. The difference is these also block serotonin receptors. And what are these used for? Well, these are labeled for bipolar disorder, depression, and schizophrenia. However, they're also used off-label for delusional disorders and obsessive compulsive disorder. A lot of these drugs are used first line sometimes for bipolar. You'll know bipolar also, we didn't clarify a first line. Sometimes it's lithium, sometimes it's second gen, sometimes it's valproate, sometimes it's lamotrigine. Completely depends on the provider and the patient situation. Adverse effects of these: metabolic effects, such as messing with your cholesterol, messing with diabetes, messing with your weight. And we're going to discuss more about metabolic effects later on. But these drugs can cause metabolic effects. Again, it's a relatively low risk. These drugs can cause EPS, but especially for test purposes, know that the risk of EPS is much, much lower in the second gen or any of these drugs, as opposed to Haldol or chlorpromazine, etc. And these can also cause orthostatic hypotension. Of all the drugs on this list, only one of them, which is Zypresidone, which is Geodon, is used for acute psychosis. Remember, of the first ones, only one of them, Haldol or haloperidol, was used for acute psychosis. So in total, we have 2 that are used for acute psychosis, haloperidol and Zypresidone. The rest of them are not meant to be given for acute episodes of psychosis. All of the antipsychotics have the exact same black box warning that they're not to be used for dementia related psychosis. And again, they have the same thing, that the medication, they have a high risk of non-compliance. And if they are non-compliant, they have an extremely high rate of relapsing. Again, also schizophrenia patients should be recommended to be in therapy as well. Thank you so much for watching. Have a great day.